بسم الله الرحمن الرحيم. ان شاء الله نبدا اخر سيشن عشان الوقت. طبعا يعني برحب بكم كلكم في مؤتمر النيوروماسكولار الخامس. طبعا بشكر اساتذتنا الكبيره اور موديل دكتوره ناجيه فهمي على مجهودها الكبير والبريزيستنس اللي اتعلمناه منها، وكل مدى ان شاء الله في تقدم وتطور. يعني هي طبعا بايونير في زي ما سمعنا في المجال دوت في مصر والشرق والريجن كلها والعالم ان شاء الله، واحنا يعني بنحاول نقلدها كتير. طبعا معايا اخويا وحبيبي الدكتور ايهاب الصعيدي كوتش الجلسه ان شاء الله. طيب نبدا باول محاضره. طبعا يعني دكتوره رضوى دي يعني اخت صغيره ويعني ايقونه الجروب عندنا نيوروماسكولار، والاسم الناس الجميله خلقا وعلما ولا فخور بها دايما. هتتكلم على clinical and epidemiological characteristics of ALS in Egyptian cohort. اتفضل يا دكتور عبد.
شكرا جزيلا دكتور علي، وطبعا يعني بشكر حضراتكم على الصمود والبقاء حتى الان. انا عارفه ان اليوم كان طويل، وعلى مدار اليوم دكتوره ناجيه ادتنا يعني محاضرات ودكتوره علا وادونا امال كبيره، واحنا الحقيقه دلوقتي للاسف هناخدها منكم. هنتكلم عن الكلينيكال والابيديميولوجيكال characteristics of ALS in an Egyptian cohort. وده الحقيقه يعني as we all know, ALS is a fatal neurodegenerative disorder. Usually the patients die within 2 to 3 years, sometimes 3 to 5 years according to different studies. مش فارقه كتير، بس يعني المشكله انه معظم الستاديز بتبقى heterogeneous جدا clinically والبروجنوزس بتاع العيان، ومعظم الستاديز كمان based على clinical وابيديميولوجيكال ستاديز يوروبيان او ويسترن، لكن الاسهام بتاع الايسترن populations او الاذر regions other than Europe وذا US قليل جدا. فدي مشكله، لانه الحقيقه لما تكون حاجه هيتروجينس والبروجنوزس بتاعها في مشاكل، وكمان الباثوفيسيولوجي نفسه مش مفهوم، وانت لسه قاعد بتتكلم عن انك بتكمبير وبتاخد الشيت فاكت من populations ثانيه، فده لحد دلوقتي عامل لنا مشكله. That's why we conducted our study to describe the epidemiological and clinical characteristics of ALS in Egypt. So we have conducted a prospective hospital-based study في neuromuscular unit عين شمس. The patients were recruited consecutively from 2018 till 2023. All the patients were diagnosed according to the revised LS-Curiel criteria, and we tried to record the clinical with demographic data. We tried to record the functional rating scores, الستيجنج سيستم بتاع العيان، الكوجنيشن، ولو في اي حاجه ثانيه مثلا اكسترا موتور مانيفستيشنز، اي حاجه البيشنت كنا بنلاقيها ممكن تفيد في الابيديميولوجي كنا بنحاول ان احنا نكولكت. مور اوفر حاولنا نقيس الريت اوف ديزيز بروجريشن، لان احنا لاحظنا انه في كده يعني unsteady progression. في بعض العيانين البروجريشن بيبقى very fast، في بعض العيانين بيبقى البروجريشن very slow. هل في امباكت بتاثر على ده؟ ايه الفاكتورز عشان على الاقل خالص لو مش هنقدر نعالج نبطئ فعلا الكورس for real. We calculated the disease rate of progression بالmean point of decline في ALS functional rating score. So what did we find? Firstly, the demographic data. We had a total of 203 ALS patients. 146 were males and 57 were females, with a male to female ratio 2.5. The median age at presentation, not at the disease onset, this is the presentation of the patient to us, was 42 years old. And the consanguinity was positive in 34% of the cohort, with 18% of patients familial cases. 76% had spinal onset, whereas bulbar onset was seen in 24% of cases. The median disease duration was 2 years old, with an IQR of 1 to 4. And 64% of the patients received riluzole 100 milligrams daily, while 20 received combination therapy of riluzole and idrabone. This is the demographic and clinical data table. بيورينا بس الفروقات ما بينهم، ودي تكملته. بدأنا نحاول نكمبير different types, different site of onsets, different age groups علشان نحاول extract الداتا. Comparing the spinal والbulbar onset, we found that bulbar ALS patients tend to have older age of onset. كان المين بتاعهم 41 years old, وكان عندهم worse cognitive performance which is kind of expected لانه فعلا في الليتريتشر لقينا انه معظم الستاديز بتريبورت ان البالبر patients بيبقى عندهم more cognitive decline. كان ده بالنسبه لنا significant لان احنا قسناه بالايكاس او الفاليديتد Edinburgh cognitive scale وكان فعلا عندهم significantly lesser median scores. بينما مثلا ال ALS functional rating score بالنسبه للعيانين بالبر او spinal at presentation was nearly the same. طيب جينا للايج اوف onset ولقينا ان المين age of onset in our cohort globally was 38 years which is a scary number to say because we are talking about ALS. It's a neurodegenerative disease. So we try to stratify patients into age groups, 3 different age groups. The first one is the juvenile age group, which is that the patient starts the disease below 25 years of age. The second one is the young onset, where the patient starts from 25 up till 45. And then the last one is the late onset group, which the patient starts the disease older than 45. And we did not invent this classification. This is a classification out there, but it's not popular. And guess why? Because these types are very rare. The juvenile ALS is a very rare entity, as well as the young onset, by the way. But the classic ALS is usually the late onset, so no one needs to classify patients because there are usually some rare cases in the epidemiological study. But when we have large numbers, we had to stratify patients in order to compare them and see what affects those patients, what differs clinically, what differs in the rate of progression, and so on. First of all, the juvenile ALS group. We found 39 ALS patients constituting 19% of the cohort. And for juvenile ALS, you find that the patient started before the 25 years of age to develop symptoms, and he has a clinical picture sure of ALS before the age of 25. The mean age of them was 18. ايه ال 18 ده المين ايج في الجروب ده بس، يعني العيانين كلهم اللي بدأوا قبل سن 25 كان المين ايج فيهم 18. يعني فاهمين قصدي؟ يعني واضح تمام، لان احنا عملنا المين ايج از هول لكل الكوهورت وعملنا المين ايج في كل جروب كمان. 84% had spinal onset ALS while 16 had bulbar onset. 74% of the cases كانوا sporadic while 26% كانوا familial، و 26 دي برضه percentage عالية جدا في فكرة familial cases. بس as we are talking about juvenile cases ف it's not that high لأنه هما الاثنين في الآخر they are generic until proved otherwise. في السكند جروب اللي هم اليونج onset ALS, this represented 37% of the cases, 76 patients. with a mean age of onset within الجروبس اللي بدأوا من سن 25 لحد سن 45 كان المين age of onset فيهم 36 سنة. تمام؟ طب والليت onset كانوا دول 44% وكان المين age of onset فيهم 55. طب let's just take a look. يا جماعة احنا بنتكلم انه قبل 45 ده this is very rare. احنا هنا بنتكلم في الكوهورت عن انه 37% young onset و 19% كانوا juvenile. This is 56% of the cohort. يعني it's scary actually. طيب وكمان في حاجة كمان لو حد مثلا بدأ يلاحظ معانا المين age of onset في اليونج onset 36 والمين age of onset في الليت onset 55. احنا هنا بنتكلم عن انه حتى المين ايج within الجروب ده مش على الابر اند اوف ذا رينج، يعني 36 ده بالظبط ميد واي، يعني كانك مثلا بتقول من 25 ل 45 ده في النص 35 36 فاهمين؟ فانت مش بتتكلم ان هو كل بيشنت على الاولدر بوينت بتاع الرينج. Then we started to compare these age groups and we found that the juvenile had significantly higher consanguinity. كان 51% من العيانين دول of consanguineous parents، وده عشان كده لازم ناخد بالنا من الفكره دي وندرس البوبيوليشنز بتاعتنا، لان ده مثلا مش موجود اطلاقا في الويسترن populations، فاحنا عارفين ان هنا الريسك فاكتورز بتاعتنا مختلفه. كمان قلنا كان في significant higher familial cases which was 26%. Moreover, we found that the presence of family history of other neurological disease كان أكتر بكتير في الجوفينايل cases. يعني مش بس neuromuscular disease، مش بس مثلا نلاقي العيان ALS بس within the family في SMA، في patients كان عنده حاجات تانية في المصل، كان في عيانين dystrophy أيا كان التشخيص، بس كمان neurological diseases as a whole، epilepsy، MS، ataxias، movement disorders، you name it. حاجة تانية كانت ال presence of extramotor manifestations، ولقينا ان ال presence of extramotor manifestation كان highest برضه في الجوفينايل cases، وكان أقل حاجة في ال late onset group اللي هم الأكثر من 45. فبدأنا نحاول نقارن برضه العيانين ونشوف ال differences سواء cognitively سواء scores سواء في ال different parameters. ولقينا طبعا زي ما اتفقنا ان الconsanguinity والتايب بتاع الفاميلي ولا sporadic دول كانوا الحاجات السيجنيفيكانت. فقلنا اوكي احنا عايزين نقيس الريت اوف بروجريشن. الميديان ALS functional rating score للعيانين at presentation كان 34.5 which is an average number تماما. يعني في معظم العيانين دول هتشوفهم هيبقى ده الايه الرقم. ال ALS functional rating score الماكسيمم بتاعه 48 وكل ما الرقم عالي كل ما كان احسن. يعني احنا كل ما الرقم قل بقى البيشنت حالته اسوء. طيب الريت اوف ديزيز بروجريشن احنا قلنا انه بيبقى assessed sequentially. انت بتقيسه at presentation and then with each follow up وبتحسبه كمين points declined per month من الفانكشنال سكور ده. فده اللي عملناه ولقينا انه المين بتاعنا كان 0.7 which is برضو an average number. فقلنا طيب الله امال ايه؟ ما هو احنا عندنا اهو ان البيشنتس بيديكلاين بس بستيدي ريت والبروجريشن بتاعهم within average زي بقيه الاستاديز. ليه حاسين ان عيانينا اسوء؟ لما بدأنا نجرب ونشوف كده باللينير ريجريشن اناليسيس لريت اوف ديزيز بروجريشن لقينا ان في significant increase في الديزيز بروجريشن في الثيرد ستيج compared للفيرست. واي حد شاف patients ALS هيبقى عارف انه هو فعلا الديزيز عمره ما بيمشي ستيدي. العيان مش بيفضل يسوق جرادوال بروجريسيف بنفس الريت طول الوقت. بتشوف البيشنت كل فولو اب بس في within مثلا فولو اب النهارده وكمان 3 شهور تشوفوا within those follow ups في مره هتيجي تلاقي البيشنت انت اتصدمت من فكره ايه deterioration ده كله. انت المره اللي فاتت كنت جاي ماشي مثلا محتاج minimal support from one side، النهارده جاي في 2 مسندينك عشان بس تعرف تيجي، او تلاقي العيان مثلا develop neck drop واضح وهكذا. فده اكد لنا شكوكنا ده ان فعلا العيان at a certain stage البروجريشن بتاعه بيتسارع جدا. بدأنا كمان نشوف الكومباريزن بين الريت اوف بروجريشن اكروس الايج جروبس ولقينا انه اليونج اونست ايج جروب اللي هم اللي من 25 ل 45 دول اعلى جروب في الريت اوف بروجريشن، اسرع جروب بيسوق. ودي اكشلي كانت حاجه احنا يعني ايه بنشك فيها شويه بس ما كناش متاكدين. لما طلعت لنا بالريزلت كنا حاسين انه اتس توتالي ريليتابل. بينما الجوفينايل ALS كانوا الليست ريت اوف ديزيز بروجريشن. بس ده ما يفرحناش لانه اكشلي الجوفينايل ALS ده لو حد قرا عنه في كتب مثلا تكست بوكس قديمه كان actually بيعتبر some sort of a benign form of ALS، حاجه slowly progressive تقريبا exclusively spinal onset، لانه عشان ما بيجيش بلبر، عشان ما بيجيش بلبر فهو ايه؟ فهو benign، عشان كده العيان بيستمر كتير، لانه طبعا البلبر يعني البلبر افكشن هو اللي بيأثر على السرفايفل يعني اسرع حاجه. طيب بالنسبه لبقيه الحاجات اللي اثرت على الريت اوف بروجريشن لقينا برضو انه في correlation significantly مع البريزنس اوف اكسترا موتور مانيفستيشن ات ذا برزنتيشن. وده خلانا نقلق تاني من فكره العيانين الجوفينايل، لان احنا قلنا انه 50% منهم كانوا اوريدي عندهم اكسترا موتور مانيفستيشنز ات برزنتيشن. فده قلقنا من انه العيان ممكن فعلا البروجريشن بتاعه يبقى اسرع مما نظن او من اللي احنا كنا فاكرينه عن الجوفينايل ALS. دي الكومباريزنز بتاعتنا. ولكن قلنا طب خلاص احنا هننسى كل اللي فات ونفتح صفحه جديده ونتكلم عن الريت اوف بروجريشن وعلاقته بالتريتمنت انتيك، مش كده؟ تمام. لا برضو لا. لقينا في الاول مفيش اي فرق، يعني في التيبل اللي فات مفيش اي فرق بين العيانين اللي كانوا تريتد واللي مش تريتد، وطب الموداليتي اوف تريتمنت مفيش اي فرق، وكنا محبطين جدا الحقيقه. بس بعد كده بدانا نحاول نعمل لينير ريجريشن اناليسيس، لقينا ان في significant نيجاتيف كورليشن مع الريليزول ثيرابي ومع الكومباينيشن ثيرابي، الريليزول والادرافون. بس ما فرقش خالص العيانين اللي خدوا ادرافون بس، يعني لو حد مشي على ادرافون سايكلز واحنا اسسنا البيشنتس وكملنا معاه في الفولو اب ات برزنتيشن وات فولو اب ما فرقش خالص، والعيانين برضو اللي ما كانوش تريتد. بس هنا في حاجه انا بحس ان احنا لازم نقولها من باب الشفافيه، انه برضو الاعداد يا جماعه ما كانتش خالص يعني كومباربل. 64% كانوا بياخدوا رايلوزول و20% كانوا بياخدوا كومباينيشن ثيرابي، فالباقي اصلا اللي ما كانوش تريتد او اللي كانوا تريتد بادرافون بس قليلين قوي. فدول كانوا يعني مش حاجه مثلا statistically هتبقى انت عارف ان هي 100% accurate، at least that's what I believe يعني. تمام. ده جدول اللينير ريجريشن. لكن احنا هنتكلم عن الدايجنوستيك ديلي. لقينا الحاجات الاكسبكتد، لقينا ان العيانين الافريج دايجنوستيك ديلي بتاعنا بيبقى غالبا سنه، بس بيبقى لونجر سيجنيفيكانتلي في اليونجر ايج جروبس. الجوفينايل كيسز كانت اطول كيسز طبعا على ما بتتشخص، وطبعا كان اطول شويه في السباينال والفيميل، في السباينال ALS او السباينال اونست وفي الفيميلز. وده بيأجري مع دراسه اتعملت قبل كده من دكتور هبه الله راشد ودكتور محمد امير، عملوا فيها الكلام ده. ويعني دي جداول المقارنه بين الدايجنوستيك ديلي among different groups. فبدانا نحاول نعمل ريزلتس اناليسيس، واحنا في ريزلتس اناليسيس معظم الكلام قلناه، اتكلمنا عن الميل بريدوميننس وقلنا انه ده كايند اوف اكسبكتد في كل الاستاديز، بس كانت الريشيو بتاعتنا اعلى شويه من الويسترن بوبيوليشن. بس اول ما بدانا نقارنها بالستاديز اللي اتعملت في تونس او في ليبيا او في المغرب، لقينا انه الارقام توتالي كومباربل، هم ارقامهم 2.3 to 1 2 to 1. في بعض الافريكان ستاديز اكشلي طلعت نسبه 2.9 او 3 to 1، يعني 3 فيميلز to 1. فالفكره انه لقينا انه لا، في حاجات، في certain exposures احنا هنا بنغفلها في مجتمعاتنا. الفاميليال كيسز قلنا كانوا 18% وكانوا significantly higher في اليونجر جروبس، وبرده ده كان totally expected، ولقينا معاهم family history لحاجات ثانيه. كل ده كان بيبوينت لفكره ان في possible genetic etiology that's probably augmented by the presence of consanguinity in our population. قلنا ان المين ايج كان 38، بس لقينا انه قلنا طب خلاص احنا لقينا في اليونجر جروبس، لقينا ان احنا مثلا في الميل بريدوميننس احنا متفقين مع المجتمعات العربيه او الدول العربيه والدول الافريقيه. طب في الايج اوف اونست هنا كانت المشكله، انه لقينا ان الايج اوف اونست بتاعنا في 38 ده اصغر بكتير حتى من الدراسات اللي اتعملت في تونس او في ليبيا او في الدول الافريقيه. لانه مثلا التونيجيان epidemiological studies كانت مطلعه ان المين ايج اوف اونست 55 which is a lot older than our patients. لقينا ان دراساتنا بس اتفقت مع الشاينيز ستاديز. الدراسات الصينيه طلعت كده معظم العيانين المين ايج اوف اونست بتاعهم في الاربعينات، فده خلانا نحط كده علامه استفهام ونحس انه طب احنا ايه الكومن بيننا وبين الصين غير الزحمه يعني والتلوث، بس في حاجات ثانيه. بدانا نحاول نقارن، لقينا تاني قلنا طيب الحاجات الفاميليال والحاجات الجوفينايل دي كلها حاجات جيناتيك، خلاص يبقى احنا الهاي برسنتج اوف الفاميليال كيسز والجوفينايل كيسز دي اتريبيوتد للكونسانجوينيتي، يمكن احنا عندنا كونسانجوينيتي اعلى من بقيه البوبيليشن. بس اللي كان برضه ديسابوينتنج ان لما قارنا بالتونيجيان ستادي، ودي عشان دي ستادي حديثه، يعني دي ستادي اتنشرت في 2020 كان معاهم 210 عيان واحنا معانا 203، فالارقام كومباربل. ولقينا كمان ان الكونسانجوينيتي ريتس في التونيجيان ستادي 30% واحنا عندنا 34. فلما تبقى الارقام كومباربل قوي كده واحنا الاثنين في الاخر يعني دول عربيه وشمال افريقيا، الحركه بركه، فاللي هو ايه، انت متوقع انك تلاقي حاجات كتير كومن بين التو بوبيليشنز دول، غير طبعا السوشيال والديموغرافيك كومن فيتشرز. تمام خلاص، فبدانا نبقى معتقدين ان احنا فعلا عندنا حاجه بتسرع شويه الديزيز بروجريشن. ولقينا ان في البالبر اي ال اس مثلا العيانين بتوعنا قلنا ان هم اكبر، وده طبيعي او يعني اكسبكتد في كل الاستاديز، بس لقينا ان كل ما البيشنت يعني برسنتج اوف بالبر اي ال اس بتزيد مع الايج. في الجوفينايل كانوا 16%، في اليونج اونست كانوا 21، وفي الليت اونست كانوا 29. ده خلينا نفكر ان في الريت اوف ديزيز بروجريشن بتاعنا وفي البروجنوزز بتاع العيانين بتوعنا لازم نبي اتنشن لاذر مانيفستيشنز او لاذر فاكتورز اللي ممكن تبقى نجلكتد في الاستاديز يوجوالي. فخلينا مثلا نقول انه الرول اوف السايت اوف الديزيز اونست ده بالنسبه لنا ما كانش كونفيرمد. يعني ايه؟ يعني العيان في العادي في اول اي حاجه مثلا هتقرا منها البروجنوزز بتاع ال اس هيقول لك ان اهم حاجه هو السايت اوف اونست. العيان ده السايت اوف اونست بتاعه بالبر، البروجنوزز بتاعه سيء جدا. العيان ده السايت اوف اونست بتاعه سباينال، البروجنوزز بتاعه افضل شويه. ده ما لقيناهوش خالص عندنا. ليه؟ لانه اكشلي احنا دايما معتقدين انه يعني في الاول كنا زمان بنكروس توك كده بين الفينوتايب والسايت اوف اونست، لكن لو احنا التزمنا بالليتريتشر بالظبط بحذافيره زي ما هم بيقولوا ان هي على السايت اوف اونست، ما بنلاقيش العيان ماشي كده. ساعات العيان يبدا بالبر بس بعد كده الفينوتايب بتاعه يكمل كانه سباينال، والعكس صحيح. تلاقي عيان كان بادئ اصلا بريست دروب، بس العيان دلوقتي قدامك لو انت جيت شفته بعد سنه تديله فينوتايب بالبر، بس احنا ساعتها هنحطه ايه؟ هنحطه ان هو السايت اوف اونست ايه؟ على حسب السايت اوف اونست. فلقينا ان دي مش مظبوطه، المظبوط هو الفينوتايب مش السايت اوف اونست خالص. كمان ما لقيناش مثلا يعني كورليشن بين الريت اوف بروجريشن والبريزنس اوف كوجنيتيف امبيرمنت، لقيناه مع الاكسترا موتور از هول. يعني ايه؟ يعني لو العيان عنده اوتونوميك، لو العيان عنده حاجات اكسترا بيراميدال، حاجات انفولانتري، اي حاجه ثانيه بس مش بس الكوجنيتيف. وده كان مش متفق مع معظم الاستاديز الويسترن، بس لقيناه متفق مع مين؟ ولا الصدفه البحته؟ الصين. برضو الصين حلوه. فلقينا ان هو برضو الدراسات الصينيه هي الوحيده اللي بتقول انه السايت اوف اونست مش هو الفارق، وان الكوجنيشن لوحده في الاكسترا موتور مانيفستيشنز ممكن ما يبقاش هو اللي فارق قوي في البروجنوزس، مش هيسرع لك الداث بتاع العيانين. احنا بنتكلم عن الاند بوينت هي السرفايفل نفسها ولا العيان مات. تمام؟ فده كله خلانا نفكر اكتر في يعني شيرد انفايرمنتال اسبيكتس بيننا وبين الشاينيز بوبيوليشنز، او انه على الاقل خالص في ديفرنت بروفايل لل prognostic factors. مش هم مثلا الليسته المحفوظه اللي بيتكتبوا لنا في كل حته، لا، هم في other prognostic factors ممكن احنا محتاجين نطورها او نغير ترتيبها، هم مش بنفس الاهميه في كل البوبيوليشنز. طب الليميتيشنز بتاعتنا ايه؟ الليميتيشنز بتاعتنا ان دي tertiary care center، فطبعا الريبريزنتيفنس اوف اور داتا از توتالي restrained، لانه احنا خلاص احنا عارفين ان الريفيرد بيشنتس هم العيانين اللي عندهم سبيشال كايند اوف كيسز مش العاديين. كمان دي حاجه observational فبتهندر اي obtaining يعني للكوزال ريليشن شيبس، هل ده السبب ولا دي مير اسوشيشن. حاجه كمان هي فكره ان الفولو اب بتاع العيان بيصعب كل يوم عن الثاني، فبالتالي عندنا دروب اوتس كتير لانه معظم العيانين بيبقوا من يعني different regions، حاجات بعيده. واخر حاجه انه في lack of genetic studies to identify genotype phenotype relationships، بس ده بنحاول نعمل عليه. معانا دكتوره نبيله هتكلمنا عن الجينوتايب بتاع عيانين الفاميليال. In conclusion, the epidemiological and clinical characteristics of Egyptian patients prove that في حاجات common بيننا وبين الليتريتشر وحاجات تانية مختلفة. عندنا more familial cases, more male predominance, younger age of onset, and more juvenile cases that may not be entirely slowly progressive أو benign form زي اللي احنا كنا فاكرينهم. والconclusion بتاعنا إن ده notable لأنه ده disease poorly understood. ولسه في حاجات كتير قوي في unanswered questions. And what you can't understand, you can't change. Thank you so much.
شكرا جزيلا دكتوره رضوى على هذه المحاضره القيمه. سؤال بس يا دكتوره رضوى، هو الادرافون اديتيه ازاي؟ يعني موجود في مصر؟ يعني كل البيشنتس خدوا؟
نعم؟
البيشنتس كلهم خدوا؟
لا 20% بس من البيشنتس خدوه ان كومباينيشن مع الرايلوزول من الكوهورت من
رايك في
لا يعني انا رايي اللي طالع ده ان هو اكشلي لوحده عمره ما كان افكتيف، وانه ان كومباينيشن مثلا مع الرايلوزول كان في يعني كانه بيسلو البروجريشن مثلا شويه، بس اي بليف ان ده الافكت بتاع الرايلوزول نفسه، لانه احنا يعني البيشنتس اللي خدوه لوحده ما كانش فيه اي افكت، البيشنتس اللي خدوه مع الرايلوزول كان فيه افكت، والبيشنتس اللي خدوا الرايلوزول لوحده كان فيه افكت. فاي بليف لو شلنا الادرابون اتس نوت.
انت عملت اناليسيس للداتا دي، يعني كان عندك بري اند بوست وعملتوا حاجه زي كده ولا ما كانش فيه داتا؟
بري اند بوست تريتمنت طبعا يا دكتور.
طب عملت اناليسيس وستاتستكس وشفتيها بقى؟
يا دكتور امال
ما فيش
لا ما فيش.
هو منشأه منين بقى يا دكتوره رضوى؟
لا يعني ان شاء الله في البروسيس يعني
من الهند مش كده؟
نعم
من الهند.
في ناس كانت بتجيبه من الهند.
ايوه في هندي وفي ياباني يا دكتور، بس
زي الاي بي اي جي كده معظمه تيجي تديه دوت زي
اليوزلس بيجيبوا اللي من الهند.
شكرا جزيلا لحضرتك. طبعا بتقدم بكل الشكر والتقدير لاستاذتي الغاليه استاذ دكتوره ناجيه. طبعا بعد الله الفضل يرجع لحضرتك في البروموشن وفعلا البروجريس اللي بيحصل في كل الفيز بتاعت النيوروماسكولار. بشكر حضرتك جدا جدا الدعوه الكريمه، بشكر حضرتك جدا المجهود الهائل بجد والله، يعني ما فيش اكتر من كده روعه. شكرا جزيلا.
انا عايزه اعمل كومنت بس.
كومنت اتفضلي
يا رضوى، انتوا شايفينها متحمسه قوي قوي، ده مجهود طبعا حوالي 4-5 سنين. الريجستري ل 230 حاله، وازاي هي كل العيانين اعاده الكشف عليهم بنفسها وتعمل الفانكشنال اسسمنت وكل الكلام ده. فطبعا عشان كده الريزلتس بتاعتها الحمد لله هي قدرت تو ببلش هير ورك، وان شاء الله يطلع اونلاين قريب. تاني حاجه بالنسبه للادرافون، العيانين كانوا بيجيبوه من الهند، بيجيبوه على حسابهم، وفي عيانين قدروا يجيبوا الراديكافا الاصلي بتاع اليابان، والحقيقه النتائج ما كانتش كويسه. انا كنت عايزه اعمل ستادي واعمل يعني يمكن مثلا 100 عيان خدوا، يعني 2-3 اللي قالوا يعني الفاسيكيوليشن قلت، البروجريشن قل شهور بسيطه، وفي الوقت نفسه كنت بصر ادي الرايلوزول معاه، في مجموعه قليله خدوه من غير الرايلوزول، فما اداناش النتائج اللي احنا عايزينها. بعد مشكله العمله ولما الدولار عالي قوي بقت اكسبنسيف قوي ان هم يجيبوه على حسابهم، ففعلا ما بقيناش بنجيبه.
لا طبعا السادة رائعه بجد، مجهود رائع. ناو شيفت ذا نيكست سبيكر بروفيسور نبيله حمدي من جيرمان يونيفرسيتي ان كايرو. She will talk about first insights into the genetics of the familial ALS in Egypt. تفضل.
Good afternoon. It's my pleasure to be with you today. Thank you very much, Dr. Nagia, for this kind invitation and for this highly interesting conference, as usual. It's my pleasure to share with you the first insights about the genetics of ALS in Egypt. We can confidently mention that this is the first study about genetics of ALS in Egypt. And first, allow me to put the talk into its context and to say that we have established a collaboration since 2018 between the German University in Cairo, my research lab, the neuromuscular unit headed by Professor Nagia Fahmy, and the neurology department, Ulm University in Germany. Ulm University is our partner university, and we have established this nice collaboration. And our aim was actually to study the characteristics of ALS in Egypt in more depth and to compare it to the other populations, because as we know, ALS is actually heterogeneous and a complex disease, and we need to compare it across all populations in order to understand more about the mechanism of this disease. So we heard about the nice talk of Dr. Radwa, and we know now we know some basic characteristics about the disease in Egypt, like the male to female ratio. I have to adjust it, I think, to 2.8. According to the latest data of Dr. Radwa. The age at onset is about 42. If we compare to the other registries in Swabia, southern Germany, the register Swabia, conducted by Ulm University, it is around 65 age at onset, and in general in the Urals, the European register is 64. So we already see this difference, and the same difference is seen regarding the male to female ratio, which is close to 1 in the European population and the German population, and it is quite high in Egypt. We still don't have data about the incidence rate of the disease, and we are working on it. Hopefully, we will be able to construct a population-based registry in the future. And it is reported to 2.1 to 2.6 in the European and the German population, expressed in cases per 100,000 per year. So these differences, there is no simple answer to explain these differences among the population. We know it is, there is an interpopulation heterogeneity. We know it is a complex disease. However, these differences could be explained by a different genetic background, different ancestry, but also to some differences in the epigenetics and the gene regulation, and of course, environmental factors or risk factors. And that's why it is very important and crucial to study the ALS in each population and to compare the characteristics across the populations. So, and that's why our approach in dealing with ALS on the research level is a holistic research approach. We are very much interested, of course, in studying the genetic background of the disease, but also we have conducted some epigenetic studies, microRNA sequencing in ALS and sporadic patients mainly, and we compared the young onset versus old onset. And we are now currently, it's a PhD project, we are studying the metabolomics of ALS patients, and we would like to integrate the multi-omics, to do multi-omics analysis to integrate the different layers, genomics, epigenomics, metabolomics, and other layers in order to understand in depth the characteristics of the disease. We are establishing or the use of multi-omics analysis using bioinformatics and AI methodology. And of course, we are interested in epidemiology, because epidemiology, this will allow us to study the risk factors, possible environmental factors that would explain this disease, especially for the sporadic patients. And another aim is to work on establishing a registry for ALS to collect all the cases and to have a representative number of ALS patients to study the characteristics of the disease. And now focusing on the genetics of ALS, as we can see from this graph, the genetic of ALS is very complex. We can see we have many genes that are responsible for the disease. It is not one single gene that could be associated with the disease. And we see here the first gene that was associated with the disease is the SOD1, coding for the antioxidant enzyme, the superoxide dismutase 1. It was discovered in the 90s, and we can see starting 2003, which coincides with the completion of the Human Genome Project, we can see the exponential increase in the discovery of many, many genes related to ALS. So these circles that we see here, they have different sizes, and they reflect the frequency of the mutated genes. This means, and these are European data, and we will see that the Egyptian data, they are different. So according to European data, the most common gene is the C9orf72, which is on chromosome 9. It's an expansion repeat, followed by the SOD1 gene, and followed by other genes like the TAR-DDP, the FUS gene, and other genes. And we see that these circles, they have two colors, the red and the blue color. And these two colors, they mean that these mutations, they were found both in the familial as well as in the sporadic cases. In addition, we can see these different colors. We have the green, the orange, and the purple color. And this is to explain the mechanism by which these genes can contribute to the disease. We have three mechanisms. Either they are implicated in the protein homeostasis, like the SOD1, or in the altered RNA binding proteins, like the C9orf, or in the cytoskeleton proteins. So for example, if we talk about the most common genes, C9orf and SOD1, briefly to highlight their mechanisms. For the C9orf72, we can see it is an hexanucleotide repeat. It's 4G2C that is repeated at a high number, abnormally high number, okay? This happens in the open reading frame of chromosome 9. And for the mechanism by which this expansion repeat could be included or involved in the disease, we have two major mechanisms. The first mechanism is inhibition of the transcription, so we have a loss of function. This means the cells are not producing enough C9orf72, and obviously this protein is important for the motor neurons and other tissues. And on the other hand, this high expansion repeat will lead to other, what we call the toxic gain of function, by accumulating RNA or binding RNA and the formation of what we call the RNA foci inside the nucleus of the motor neurons, which are toxic to the motor neurons, in addition to the generation of abnormal short dipeptide repeats due to this expansion that contribute to the motor neuron toxicity. So for the SOD1, normally the wild type gene would produce a normal mRNA that is translated into the normal antioxidant enzyme SOD1 protein. In case of mutations, and we have several mutations, more than 200 mutations, they were described for the SOD1 gene. We have a mutated messenger RNA that will be translated into an abnormal protein, SOD1 protein, that will form aggregates. And these SOD1 aggregates, they are highly toxic to the neurons and they lead to neurodegeneration. So it's a toxic gain of function mutation, and this is actually the basic for the development of the only FDA-approved drug for as a genetic treatment for the ALS, which is the use of antisense oligonucleotides, which is a short sequence of nucleotide. It will bind to the mutated messenger RNA, and it will prevent the formation of this toxic protein. And by doing this, we are preventing the toxicity induced by this abnormal toxic protein. And this led to the accelerated FDA approval of the tofersen or Qalsody drug last year. So if I may summarize briefly the German experience in ALS genetics, because they are actually pioneers in the field. They have been working on ALS since 30 years maybe, specifically the neurology department, Ulm University, and these are actually some key publications of the German group. They could screen more than 300 familial cases, and they found that 45% of the families, or roughly 50% of the familial cases, they do have a certain genetic variant or genetic mutations in ALS known genes, with the C9orf being the most common. And they screened more than 2,300 sporadic patients within the German ALS network, and they found that in the sporadic patients as well, 13% of the sporadic patients, they do have a genetic explanation of the disease. This means 10% of them, they could be candidates for gene-specific therapies, either the approved one for SOD1 or other gene therapies or genetic-based therapies in the pipeline. And one interesting finding, which is actually specific for the German population, they discovered that the young onset patients younger than 35 years, 50% of them roughly, they have a de novo mutation in one gene called the FUS gene. And this genotype is correlated with onset of bulbar symptoms and aggressive disease scores in half of the patients. So this is to summarize the involvement or the distribution of the genes involved in the familial ALS patients in Germany. So among the 50% of the familial cases where they found a genetic explanation, we have the most common gene is the C9orf72 with 44% of the genes, followed by, in second position, the SOD1 with 20%, followed by other genes like the FUS gene, the TARDDP, the TPK1, which was actually discovered by this group. It was not reported before, but discovered by this group, in addition to other rare diseases and some variants of unknown significance. So talking now about the ALS genetics in Egypt and what was actually our approach within this collaboration. Dr. Ahmed talked previously about two schools, how to do genetic testing, and we adopted the second school, meaning we started with targeted screening, and then we moved slowly to the larger screening. So first of all, we looked for specific genes that are known, that are common, based on the European experience again, which are basically the SOD1 and the C9orf and the FUS mutations, because we have young onset in Egypt, so we thought maybe we will find the FUS mutation, which was reported in the young German patients, okay? And to our surprise, we didn't find any FUS mutations in all our patients, the familial and the sporadic patients. And we found only one family having the C9orf72, although this mutation is very common, and this is the most common mutation in the European populations in general, because it is actually a European gene. And the common mutations, they were absent in the sporadic. But we found an interesting and novel homozygous mutation in the SOD1 gene that was found for the first time in the homozygous, because homozygous mutations are really rare worldwide, okay? And this, what is interesting about this case is that this homozygous mutation caused a very severe phenotype at with young onset. This is the pedigree of the family. Parents, they were first cousins, and the patient was diagnosed at the age of 26. She had a foot drop with very rapid progression and bulbar involvement at diagnosis. Her condition deteriorated very rapidly, and death happened within 2 years. The patient had a younger brother who was diagnosed by Dr. Nagia Fahmy at the age of 12. This was juvenile ALS, and also with rapid deterioration and bad prognosis. So this family was published as a case report in the Journal of Neurology. And actually, Dr. Nakia, if you recall, we had some difficulties in publishing this case report because we wanted, actually, when we measured the SOD1 enzyme activity of the SOD1 protein, we found a very low enzyme activity. And we thought maybe this could be a loss of function mutation, and we wanted to convey the message. This was before the approval of the tofersen, the SOD1 genetic therapy. We wanted to convey the message that we need to be careful if we would like to silence the SOD1, because if we go very low with the SOD1 enzyme, you see we can have a very severe phenotype. And we had difficulties because it was sensitive for the researchers and for the pharmaceutical companies to state this, this notice just before the release of the drug. And that's why we made it, we reported in a very neutral way, and we just made it as a case report, knowing that this is the lowest enzyme activity ever reported in ALS patients. So next, we expanded our analysis to the level of the whole exome. We did whole exome analysis in order to explain the other families and the sporadic patients. And at this stage as well, we didn't find any clear genetic explanation for the sporadic, but we could actually find a genetic explanation for all families, which were 11 families involved in this study. We performed whole exome and we did a panel analysis comprising 35 ALS known genes. And this was our first publication about the genetics as a cohort, Egyptian cohort, stating the first insights into the genotype and phenotype of familial amyotrophic lateral sclerosis in Egypt, highlighting the early onset and the high rate of consanguinity. So our cohort comprised 11 families. We tested 15 patients, ALS patients, and in addition to 14 unaffected members to study the inheritance of the disease. The age at onset was around 41. 5 juvenile cases were found in these families, and the consanguinity rate was very high, exceeding 70%. For the site of onset, it was mainly spinal and 6% only bulbar. So this table summarizes our findings. So we could find a genetic variant which is classified according to the ACMG, either as pathogenic or likely pathogenic. For only one family, it was a variant of unknown significance, so it needs further study and further research in order to try to explain the link. So we had, you see, the high rate of consanguinity, which is only 3 families. They didn't report history of consanguinity, and the other families, they were positive for consanguinity. The first important finding, we found high rate of SOD1 mutations. So 4 families, they had SOD1 mutations, including the family that was published as a case report with the homozygous. The other 3 families, they have heterozygous mutations. The phenotype was, as I mentioned, very aggressive and very rapid deterioration for the homozygous, and for the heterozygous cases, it was rather slow progressive. The CNAN-OFF was found in only 1 family, with a repeat between 1,300 and 1,800. TAR-DTP was found in 1 family following the autosomal dominant, and this is a mutation that was previously reported. For the MAPT gene, it was a variant of unknown significance, and 1 family had the mutations in the SPG11, which is previously related to hereditary spastic paraplegia. However, it was recently described in ALS and ALS-like spectrum. And interestingly, these 3 families, these 3 genes, they are not actually classified among the common ALS genes or the known ALS genes, but when we expanded our whole exome sequencing analysis outside this panel, we discovered that these 3 families, they have homozygous mutations, 1 frame shift and 2 missense mutations in genes that were previously found to be associated with other neurological diseases. For example, ATP13A2 was associated with atypical juvenile onset Parkinson's, and VRK1 and DNAGB2, they were associated with other types of muscle dystrophies like Charcot-Marie-Tooth or distal SMA. So these mutations or these genes, they have been only recently implicated in ALS spectrum. So, and we found them in 3 of our families in the homozygous form. So we can see that despite the small cohort, which is 11 families, we have very rich and very distinctive phenotype with the predominance of SOD1 mutations and with the frequent homozygous mutations that are otherwise rare in other populations. So, and through or during this collaboration, we are happy to have established now the genetic testing for ALS in our GOC lab. We can do the Sanger sequencing and fragment length analysis for the expansion repeats. And we are extending our expertise to other neuromuscular and neurological diseases like SMA, Duchenne, and so on. So, in summary, if I may summarize the talk, so we see a distinctive genetic profile in Egypt if we compare it to the European populations, but even if you compare it to other African populations, we don't have many data about the genetics of ALS in Africa. The Tunisians, they publish like 1 year before us or 2 years before us, okay? And if you compare the genetics of Egyptian cohort and Tunisian cohort, already we see a difference. And not only on the phenotype level, but the phenotype genotype here, maybe it will answer some questions, Dr. Radwa. So in the Tunisian cohort, they found the most common gene is TAR-DDP, and then the C9orf, which is actually a European gene, and then SOD1 comes in the second place. And Dr. Radwa mentioned the similarity in the phenotype and some characteristics with China. And here again, you will find on the level of the genetics, we are closer to the Chinese cohorts rather than Tunisian cohorts, for example. So this is interesting. The predominance of SOD1 variants in Egypt, this is actually good news because the only FDA-approved genetic-based treatment is anti-SOD1 gene. So we hope that we could have hope for the Egyptian patients to have these genetic treatments in the near future for SOD1 or other in the pipeline. So the impact of consanguinity, we see high consanguinity among the familial Egyptian families. This means high frequency of the recessive genes. This, of course, it can have an impact on the phenotype. Severe phenotypes, and genetic counseling, of course, here is crucial. So what about the sporadic ALS in Egypt? So far, we didn't find data about the genetics of sporadic, and this shows that we need to focus our research on these sporadic, which are the majority of the ALS patients, maybe by doing whole genome, maybe methylome studies, epigenetics, and of course the risk factors, could be environmental factors or risk factors that we have to study. And in order to study the risk factors, we need a big registry. So I would like to highlight the importance of national and international collaboration to address complex diseases like ALS or other diseases, because through this collaboration we can foster knowledge sharing, we can accelerate research efforts, and we can enhance the development of effective treatments. And of course, we need to, there is a high need for ALS registry, and to establish the population-based ALS registry is essential in order to better understand the disease, to study the local characteristics of the disease in Egypt, aligned with genetics and epigenetic characteristics and biomarkers, to facilitate the research and improve patient care. And this is actually our vision and our plan to construct a population-based registry for motor neuron diseases in Egypt. This is just published in the Journal of Neuroepidemiology, and we hope that we will be actively working on implementing our aim and our initiative. And of course, I would like to thank the neuromuscular unit of Ain Shams, Dr. Nagia and Dr. Radwa and their teams. My team, we have master's and PhD students who are involved in this research. Our colleagues from University of Ulm, Professor Albert Ludolf is the director of the neurology department. Professor Zibat is the director of the human genetics department. Professor Hayretin Toumani will be talking online, hopefully in a few seconds, about the importance of biomarkers in ALS and other neurological diseases. And my colleagues, Professor Freischmidt, experts in epigenetics, and Dr. Müller, experts in genetics. And from Italy, University of Bari, we have our collaborator, an expert in neuroepidemiology, Professor Giancarlo Groscino, who is highly has high expertise in establishing population-based registries, and he is like a consultant or collaborator with us for the establishment of the registry, hopefully in Egypt. And thank you very much for your attention.
Thank you, Dr. Nabila, for this amazing lecture. And congratulations for the success of the all collaboration with Dr. Nagia, with German University of Cairo, and also other experts in Germany. بصراحة يعني الكولابوريشن مهمة قوي مع البيزك ساينتست في النيوروجينيتيف ديسوردرز، واعتقد يعني أول حاجة وجود تيم اكسبرت كلينيكالي مع داتا ريجستري، هم دول اللي بيفتحوا الطريق بعد كده للكولابوريشن، وفي بروبر اسسمنت وريفيرال، ودوت يعني بيبدا بقى كولابوريشن بره. ولما يبقى فيه زي ثقه في التيم دوت، ده بيفتح مجالات كتير زي ما احنا شفنا في مجال neuromuscular. يعني مبروك. Congratulations for this amazing papers and congratulations Dr. Nagia for this amazing publications. يعني we are very proud of this. Any questions or questions after? Any questions for Dr. Nabila? المايك يا جماعة، المايك للدكتور.
أنا هأكد على كلام حضرتك دكتور علي. الحقيقة الكولابوريشن مهم جدا جدا. احنا دلوقتي عندنا جامعات في مصر متخصصة، يعني لما الاقي تيم كبير زي دكتور نبيلة وعندهم ابتدوا تو استابليش فيري جود لاب، ويبقى عندي الشباب بتوعها، يعني مش قادرة اقول لك كمية النشاط والعلم والبحث اللي هم فيه. انا لازم اتعاون، والتعاون مثمر للكل. يعني اكيد الكلينيشن بياخد مكانه، واكيد الجينيتست بياخد مكانه، الناس بتشتغل بروتشومكس، الناس اللي اشتغل حتى على الابيديميولوجي فرقت. انا اول ما دكتوره نبيله الحقيقه زارتنا في عين شمس وقالت لي ALS، قلت لها انا عايزه الALS عشان احنا ظالمين الALS. ما كانش عندي ساعتها غير رساله واحده، كانت ايناس من اليمن، الفاكر ايناس، وكانت بتعمل ريجستري للفاميليال كيسز والسبراديك كيسز. وطبعا لان ايناس كانت بنت نشيطه جدا، ابتدت باول 4 حالات فاميليال كيسز، وهم جزء منهم اللي كملنا معاهم الاذر فاميلي. فانا عايزه اقول يعني استفيدوا من الخبرات الموجوده في مصر. عندنا جامعات مصريه، عندنا جامعات اجنبيه، عندنا جامعات اهليه، عندنا مراكز بحوث، عندنا شباب متحمس، عندنا ناس نشيطه جدا زي دكتوره نبيله دينامو قاعده بتجمع كل خبير من كل جامعه وتدخله في التيم معانا. اخر حاجه دلوقتي الريجستري، احنا معانا حوالي 7 جامعات مصريه تقريبا، 9، بقينا 9 جامعات مصريه هتشترك في ريجستري ALS لاول مره. المرض ده يستاهل مننا ان ما حدش عارف يشتغل لوحده، يستاهل مننا ان احنا ندور وراه. اخر كومنت كان من دكتور بيارني قد اللي هو من فنلندا امبارح، بيقول لي على فكره احنا بدانا نشوف ان في امراض زي ALS هيبقى ليها ديوال وتريبل جينز هم اللي مسببينه، مش جين واحد بس، مش epigenetics بس. ابتدى هو يلاقي امراض في المصل 2 جينز مسببين المرض. يعني احنا داخلين في إرق كبيره قوي. فانا يعني بدعوكم كلكم للتعاون، وخلينا نتعاون ان احنا نجمع عيانينا مع بعض ونعرف المرض الخطير ده ليه بيموت، ليه موجود في الاطفال الصغيرين. احنا عندنا اصغر طفل 10 سنين، ليه موجود في الشباب، ليه في مصر موجود في العشرينات والثلاثينات. فالحقيقه انا اشكرك جدا على الاكسلنت برزنتيشن، واشكرك على التعاون المستمر، وان شاء الله التعاون بتاعنا دايما هيفضل. شكرا لحضرتك.
Any questions for Dr. Nabila? Okay, we'll go to the next speaker.
طبعا انا يعني سعيد جدا بالكلام اللي قاله الدكتوره ناجية علي فهمي والاستاذه الدكتوره من الجامعه الالمانيه الاستاذه نبيله. انا بس بسال يعني الناس زيك يعني بيدرسوا اللغه الالمانيه، طبعا انت دارسه الماني مش كده ولا ايه؟ يعني درستي الابحاث دي باللغه الالمانيه مش كده؟ ولا انجلش بس؟ يعني طبعا انا زرت جامعه اولم ديت يعني زمان، يعني لما كنت شاب صغير، وشفت ان الالمان فعلا بيشتغلوا بطريقه مختلفه شويه عندنا في مصر. هو سؤالي يعني بالنسبه مثلا انا حاليا شغال في مرسى مطروح، هل مثلا جالك مزاج تروحي سيوه وتروحي الساحل الشمالي ومرسى مطروح؟ انت عارفه ان هناك قبائل، والاستاذ اللي انت اشتغلتي معاه في اولم بروفيسور تيوماني باين؟
توماني ودار.
تيوماني ده اشتغل في المالتيبل سكلروزيس، واخده بالك؟
والهيد بتاعت
واشتغل في امريكا في يوكلا في كاليفورنيا، وعمل ابحاث جامده قوي. هل مثلا في مخكم ان انتوا تيجوا مرسى مطروح مناطق نائيه وتشوفوا الجينيتكس والمشاكل الموجوده هناك خطيره جدا، يعني قبائل اولاد ابن علي حوالي 40 قبيله مع الحدود الليبيه. انا بيتهيألي يعني الدكتوره، يعني انا ببعت للدكتوره حالات وبقول للناس الدكتوره يعني العالمه الكبيره ناجية علي فهمي تروحوا لها في عين شمس، هو ده الحل الوحيد. لان احنا فصلنا جامعه الاسكندريه عن جامعه مطروح، في جامعه اسمها مطروح دلوقتي، يا ريت تيجي تبقي استاذه هناك او تيجي مثلا مره كل شهر تشوفي الحالات ديت واحنا نساعدك يعني، او تعملي وحده في مستشفى مطروح العام اللي انا ماسك قسم النيورولوجي والسايكاتري فيها، لان طبعا ما فيش حد عايز يروح مطروح خالص، يعني كل اللي بيجوا مطروح بيجوا من القاهره، من القصر العيني او من عين شمس او من الاسكندريه.
حضرتك يا بيه بقى انضم للمالتي سنتر ترايل دي، اكيد الدكتوره ناجيه هتدي كل الدعم، والدكتوره نبيله يعني هي دي فايده المالتي سنتر
اللي هي قالتها. بقول ان انا زرت المانيا برضه ورحت فرنسا ورحت امريكا ولفيت العالم، ويعني يا ريت الشباب كلهم
في تعاون،
يبقى في تعاون.
شرف لينا والله،
ويا ريت تبقى زياره في الصيف عشان نصيف شويه،
نروح أولم معاكي يعني، نزور جامعه أولم معاكي ومع
انا في الصيف راس الحكمه فمش بعيده على مرسى مطروح.
انا اللي بعت راس الحكمه للامارات بقى، بيقول لك الدكتور علي باع راس الحكمه للامارات، لان انا كنت مدير مستشفى راس الحكمه من 10 سنين، وبقيت اصور الشاطئ الجميل بتاع السافي، بقول ده اجمل مكان في العالم، فخدوا فكرتي بتوع السياحه.
شكرا يا فندم، عشان بس الوقت بتاعنا. المحاضره القادمه يعني الدكتوره ساره بهاء، يعني احدث الاجيال في النيو ماسكولار تيم عين شمس يونيفرستي. الدكتوره ساره هتتكلم على ابديتس اوف ALS تريتمنت.
يعني إن شاء الله بعد سارة على طول عندنا recorded lecture Professor Tomani.
Good afternoon, everyone. First of all, I'd like to thank Dr. Nagia for giving me this opportunity to speak in front of my dear professors and colleagues. Okay, today we're going to speak about updates in ALS treatment. Our agenda for today will be, first of all, I'll start with the FDA-approved drugs from the most recent, multidisciplinary approach, symptomatic treatment, and the ongoing studies. أول حاجة ال FDA approved drugs، زي ما دكتور نبيلة كانت بتقول في اللكتشر اللي فاتت، إن ال only FDA genetic based drug عندنا هو التوفارسين. توفارسين اللي هو الكالسودي. It first received the accelerated approval in April of 2023 for the treatment of ALS with patients with SOD1 superoxide dismutase 1 gene mutation. فرق ال accelerated approval من ال official approval إن ال drug has not been conclusively proven to be clinically beneficial yet, therefore it will still need to undergo more testing. Tofarsen received the accelerated approval based on reduction in concentration of SOD1 in CSF and neurofilament light chains in plasma, together with higher scores in the ALS functional rating scales, وده كان في التجربة بتاعت الفالر and أولي. الميكانيزم اوف اكشن زي برضو ما دكتور نبيله كانت بتقول، احنا عندنا الموديل ده بيشرح لنا ان احنا الهيلثي بيرسون عنده healthy DNA, healthy messenger RNA, وبالتالي بيبقى فيه normal protein is made. فعيانين اللي عندهم ال SOD1 mutation بيبقى ال DNA mutated, بيطلع a mutated messenger RNA that produces toxic protein. فهم فكروا why not to do an antisense oligonucleotide يعمل silencing أو mute ل this mutated messenger RNA, therefore the toxic protein will not be made. The route of administration للتوفارسين هو intrathecal using a lumbar puncture. بنبدأ الأول loading dose، ناخد dose every 14 days, repeated 3 times, then a maintenance dose to be administered every 28 days. Side effects included were pain, fatigue, arthralgia, myalgia, increased white blood cell, CSF count, and protein. Where unfortunately myelitis, radiculitis, and aseptic meningitis were recorded. تاني كان دواء FDA approved في سبتمبر 2022، بس الحقيقة مش هقف عنده كتير لأن الريليف ريو sadly it was discontinued due to failure to meet the primary and secondary endpoints of the initial treatment, the initial studies. فكرة الدواء إنه هو fixed drug combination لتورورورسوديول and sodium phenyl butyrate, which are targeting the damaging that occurs in the mitochondria and the endoplasmic reticulum simultaneously. Turorosodiol is a bile acid synthesized by the liver and used for treatment of patients with cholestasis. It was found that it inhibits the mitochondrial pathway of apoptosis and oxygen radical production, ameliorating the endoplasmic reticulum stress and alleviating the unfolded protein reaction. Phenyl butyrate was thought to help proteins acquire their normal shape and thereby preventing the formation of protein clumps that cause nerve cell death. Route of administration للريليفريو كان powder for oral suspension. Side effects got reported diarrhea, abdominal pain, nausea, upper respiratory tract, fatigue, salivary hypersecretion, and dizziness. نيجي للإدرافون. الإدرافون كان بيستخدم already من 2001 لعلاج الأكيوت سكيميك ستروك. هم لقوا الميكانيزم اوف اكشن ان هو free radical scavenger, neuroprotective agent with antioxidant properties that works to scavenge reactive oxygen species which have been implicated in many neurological disorders, thus suppressing the generation of hydroxyl radicals and peroxynitrite radicals. فقالوا why not كمان ان احنا نجرب نستخدمها في علاج ال ALS, and it got the FDA approval in May 2017. الراديكافا او الادرافون في IV infusion، وكمان الجديد ان هو معانا كمان oral suspension. الفكره بتاعت ان انا بدي first cycle 14 consecutive days followed by consecutive 14 days of period, and then the subsequent cycles اول 10 ايام من ال 14 يوم بيتاخدوا consecutively and then followed by a 14-day period off. The adverse effects were reported كان في gait disturbance, headache, dermatitis, eczema, respiratory failure, hypoxia, and tinea infection. ده شكل راديكافا الأورال solution وده ال IV. نيجي طبعا للموست commonly اللي موجود في مصر هو الرايلوزول. It got the FDA approval in 1995. It was primarily described in bulbar ALS to delay the onset of ventilator dependence or tracheostomy. The mechanism of action is that it's a neuroprotective drug that blocks the glutaminergic neurotransmitter in the CNS through partial inactivation of the voltage-dependent sodium channels, as well as activation of a G protein-dependent signal transduction process. Rizole also blocks some of the postsynaptic effect of the glutamic acid by non-competitive inhibition of the NAMDA receptors. الرايلوتاك أو الرايلوزول في منه حالياً 3 forms. الرايلوتاك هو اللي موجود في مصر اللي هو الأورال تابلتس بيتاخد 50 ملغ every 12 hours. في منه التيجلوتاك ده أورال سسبنشن بيتاخد برضو فيما يوازي 50 ملغ every 12 hours. وفي الإكس سيرفان وده عبارة عن أورال فيلم بيتحط على التونج برضو فيما يوازي 50 ملغ every 12 hours. Side effects reported were gastrointestinal symptoms, dizziness, asthenia, numbness around the mouth, and it is very important to monitor liver functions after, during, and before the treatment. نيجي لتاني بوينت وهي المالتي ديسيبلينري ابروتش. زي ما دكتور ناجية دايما بتقول ان امراض النيوروماسكولار ديسوردرز كلها has to be a multidisciplinary care. بيبقى المفروض معايا نيرولوجي، بالمونولوجي، ريسبيراتوري ثيرابيست، جاستروانترولوجي، نيرسز، دايتيشن، نيوتريشنست، اوكيوبيشنال ثيرابيست علشان نعمل improvement في both the survival rate and the quality of life. أكتر مشكلتين بتواجه عيان ال ALS هي respiratory والnutrition problems. دي أكتر حاجات بتعمل death و low quality of life in ALS. وللأسف إنه كل الميديكال كير موجود is only palliative. التفكير بيبقى هل أنا هبقى invasive ولا non-invasive. In nutrition لازم أمونيتور ال BMI below 18.5. This is associated with a shorter survival rate. I have to enrich the patient with caloric-rich foods, oral supplements, alteration of food consistency, and involvement of swallowing therapist. feeding tubes امتى بفكر فيها؟ لما يبقى في unsettling weight loss, insufficient oral intake, dehydration, بدأ يبقى في choking, respiratory tract infection, and I always have to consider this with the respiratory decline, as feeding tubes should be placed before respiratory vital capacity fall below 50%, as there is an increased procedure risk with this declination in respiratory status. نيجي للrespiration. It's best assessed by series of vital capacity. Below 50%, this is associated with respiratory symptoms. ممكن استخدم non-invasive positive pressure ventilation to help reduce these symptoms burden and improve the quality of life. زي ما قلنا امبارح في السكول، امتى بلجأ للفنتيلاتوري سبورت؟ ودي بتبقى لما الميجرز بتفول below the 20-30-40 rule. Vital capacity fall below 20. Maximum inspiratory pressure maximum inspiratory pressure above -30 and maximum expiratory pressure below 40. ازاي اعمل مانجمنت للسيمبتومز بتاع ALS؟ اول حاجه السباستيستي، ممكن ادي باكلوفين، ممكن اعمل بوتيلاينم توكسين، بس I have to be very careful especially with ALS patients. بالنسبة للسودو بالبر بولسي في FDA approved drugs اسمه نيودكستا. نيودكستا عبارة عن fixed drug combination من الدكستروميثورفين and كينيدين. خد FDA approval في 2010. Its mechanism of action is presumed to be through a sigma-1 receptor agonist and a lambda antagonist. والكينيدين act to upregulate the bioavailability of dextromethorphan by inhibiting the cytochrome P450 enzyme. الروت اوف ادمنستريشن بيبقى اورال عن طريق كبسولز. adverse effects diarrhea, dizziness, vomiting, asthenia, peripheral edema and flatulence. Newdexta is not available في مصر، وبالتالي الالترناتيفز ممكن تبقى TCA and SSRIs. بالنسبة للهايبرساليفيشن أو السيالوريا, we can use anticholinergic medication. However, they may produce unacceptable side effects, especially in the elderly population. Therefore, alternatives are radiation therapy and ultrasound-guided botulinum toxin injection. Thickened secretions can be dealt with by increasing the fluid intake, air humidification, using mucolytics such as N-acetylcysteine. آخر حاجة هتكلم عنها هي ال recent ongoing studies. في studies كتيرة جدا لحاجات شغالين فيها برا. For example, في شغالين مثلا على agent اسمه الماستينيب. It's a tyrosine kinase inhibitor. بيبلوك الميكروغلايا proliferation and activation and mast cell mediated degranulation. و it acts as a neuroinflammation. عندنا مثلا الإبيوديلاست, again it's inhibition of the macrophage migration and it's still an ongoing study. في كانوا شغالين على حاجة similar للتوفارسن, an antisense oligonucleotide بس للC9 orf اسمه tadnursin, بس unfortunately the studies is not meeting the endpoints, so the study will be discontinued. And many other agents as well, hopefully to produce genetic-based medications for ALS patients. Last but not least, the therapeutic approach using stem cells has been promoted as a potential neuroprotective therapeutic strategy for ALS. In particular, mesenchymal stem cells have multiple effects, such as stimulation of the intrinsic neurogenesis, the release of various neurotrophic factors, and modulation of the immune inflammatory processes, transforming the patient's environment from a pro-inflammatory toxic state to an anti-inflammatory and a neuroprotective state. Thank you very much.
شكرا جزيلا دكتوره ساره على هذه المحاضره القيمه. ميرسي جدا. Now we come to the last lecture will be online. Professor Hartine Tomani. He is head of CSF laboratory and WG clinical biochemistry. Head outpatient unit MS and neuroinflammatory diseases, Department of Neurology, University Hospital ULM at RKU. He will talk about biomarkers in neurological diseases from CSF to blood-based analysis. طبعا بتقدم بكل الشكر للاخ الفاضل الاستاذ الدكتور علي شلش اللي منورني النهارده، وبتقدم بشكر جزيل تاني للاستاذه الدكتوره ناجيه وكل الساده الحضور. ان شاء الله نشوف الاونلاين.
Hello from Ulm to Cairo. Many thanks for your kind invitation to this nice conference. I really would have liked to give my presentation face to face instead of participating online. I hope for next opportunity. I would like to thank all organizers, especially Professors Najia Fahmi, Radwa Soliman, and Nabila Hamdi for giving me this opportunity to share with you the topic on wet biomarkers in CSF and blood with the focus on ALS. A general definition of biomarkers is that a biomarker is objectively measured and evaluated and may serve as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. Biomarkers become increasingly important in the medical field, in diagnostic as well as in therapeutic areas. As you see on this cartoon, an ideal biomarker may support the early and precise diagnosis in order to start the individualized treatment as soon as possible. A major role may also be to show the treatment effect before the clinical endpoint has been reached, which is applicable on the individual level as well as in clinical trials. In neurological diseases, especially degenerative disorders of the CNS, CSF analysis receives an increasing importance diagnostically because it may reflect the pathological processes such as axonal and neural damages, and therapeutically because emerging new therapies such as ASOs, antisense oligonucleotides, may be applied by a spinal tap, such as the case for intrathecal application of nusinersen in the treatment of SMA, or tofersen in the treatment of ALS. And this illustration shows that roughly half a liter of CSF is produced daily, although the CSF space makes up only around 120 cc. This means that CSF drawing of 10 cc by lumbar puncture will be produced in about half an hour. So feel free to draw as much CSF as possible. It will not hurt the patient. In the remaining part of the lecture, I will focus on general issues of CSF, and secondly, its use in routine analysis and research. When did CSF diagnostics start? What was the main intention of describing the lumbar puncture as a procedure? Lumbar puncture was described more than 130 years ago by Heinrich Irenaeus Quincke, a physician of internal medicine. At that time, neurologists were not available in Germany, and he described the lumbar puncture in patients who had infectious meningitis, and in order to relieve the patients from the CSF pressure. Some of them survived this, but not all of them. And this was the beginning. And what happened since then, after the lumbar puncture was introduced. CSF became an important diagnostic tool, and the milestones are summarized in this very busy slide. Here, the beginning of the lumbar puncture more than 130 years ago, and here the current state of CSF diagnostics is this integrated CSF analysis report by Hans Otto Reiber. To make it simple, three major phases can be described. In the first phase, only rough methods like cell count and qualitative detection of proteins and gamma globulins were possible. These were the first years. In the second phase, the electrophoresis was invented and isoelectric focusing became available, and as you see here, the gamma globulin band, which was only roughly detectable by electrophoresis, in isoelectric focusing it was much better visible. And then the cytology field made also advancement by introducing the cell sedimentation chamber by Zeig in East Germany at that time, and so the differential cell count became much better, and later on flow cytometry followed. The third phase was dominated by better understanding of the CSF space, CSF anatomy, CSF physiology, and the immunoglobulin synthesis formula has been developed from the 1980s on, and since then the modern CSF analysis episode began, and more specific markers and technologies have been developed up to dementia markers or RT-Quick test, for instance in Creutzfeldt-Jakob disease or in some other neurodegenerative diseases, liquid biopsy for neuro-oncology disorders, and many other CNS-specific biomarkers, not only in CSF, meanwhile also in blood. And I will try to summarize some of these major milestones in the following part of this lecture. So, where are we now with the current state of CSF analysis? This is again a very busy picture I will walk you through. So the CSF analysis is done usually in parallel with blood analysis, latest at the time when the protein diagnostic is done. The cytology can be done in CSF alone and combined with some protein analysis, including total brain and lactate, which makes up the emergency lab. Then we have the basic program, and in the basic program the protein diagnostics will be done in CSF supernatant. These, the main proteins are albumin, IgG, IgA, and IgM, and these have to be analyzed in parallel with serum to build up the ratio in order to capture the blood CSF integrity and in order to calculate possible intrathecal synthesis of these immunoglobulins. This is the basic program. It can be expanded by oligoclonal IgG bands methods if the question is whether inflammatory process in CNS is available or not. If the question is there a specific inflammatory process going on because of presence of inflammatory signs based on oligoclonal bands or immunoglobulins intrathecally synthesized, then we can look for pathogen-specific antibodies and specify the inflammatory process. If the clinical question is neurodegenerative disease, then we can go for CNS-specific proteins like dementia markers and try to confirm or rule out diseases with dementia or other degenerative diseases. So the important part is that all possible assays or test results are integrated in one result, so we can give a descriptive result like is there inflammation going on, is it acute or chronic, is it caused by pathogens or of autoimmune nature, is there a dysfunction of the CSF circulation or barrier integrity, are there tumor cells, and so on and so on. And here are some of the tests shown. The cytology, for the cytology we need the light microscopy, the Fuchs Rosenthal chamber, which has been also now for more than 130 years ago available, and then the differential cell count. Here we have the protein diagnostic and the basic program, including the diagram illustration introduced by Reiber in Germany. Here we see the albumin quotient in the x-axis, in the y-axis the IgG quotient CSF to serum, and then depending on the results we will receive typical patterns, result patterns. This diagram combines 4 single parameters: albumin in CSF and serum, IgG in CSF and serum, and those would be a normal value. This would be a result representative for blood CSF barrier damage, light or severe. Here we would have intrathecal synthesis of IgG with normal blood CSF barrier integrity, and here we would have a combined intrathecal synthesis, inflammation in the CNS combined with blood CSF barrier dysfunction. And then the more specific tests will follow, usually by ELISAs and more sensitive technologies as will be followed later. And at the end, again, all results will be integrated, and if there is clinical information present, the results can be interpreted in the context of the clinical data. So this is the standard of the CSF analysis that is recommended by the guidelines of the German CSF Society and Clinical Neurochemistry, which has been also published a few years ago. So let me get to the second part, which is about CSF as a biomarker in routine and research. And here I will focus more on ALS. But let's start with a typical integrated CSF report, how we do it here in Germany, in Ulm. Here you see this very complex report sheet where here we have the clinical information, why the CSF was taken and what the request is. Here in this case is there an inflammatory process, it was a suspected MS case. So, and then here we have the lumbar puncture, and we have the visual inspection, and then puncture time, and then we have here the results beginning with the cytology, total cell count, and then the differential cell count. We have here the proteins in CSF, proteins in serum. Here's the quotient, and here whether intrathecal fraction is present or not. If yes, we would see it here in this quotient diagrams. For instance, 73% intrathecal IgG synthesis would show up here. IgA is not produced intrathecally, so it's here in the normal area, but IgM is produced intrathecally and it will show up here. And the barrier is normal, albumin quotient is 2.7. So then we do specific antibodies against measles, rubella, zoster, and herpes. and if needed also for others. And in multiple sclerosis, it is very typical that antibody index values against measles, rubella, zoster may be present. If this is the case, this is an indication for us that a chronic inflammatory process is going on, and this would confirm diagnosis of MS. Lactate or glucose should be here normal. So this would be then commented and interpreted as a compatible result with chronic inflammatory process, also compatible with multiple sclerosis. But our focus should be, here is oligoclonal bands, and in the oligoclonal bands are of course also positive. And here we have the 5 different types: type 1, type 2, type 3, type 4, type 5. And type 2 or type 3 means that intrathecal IgG is produced, and in this patient type 2 was present. So this is also confirming the inflammatory process that we already have seen in this diagram. And so this would confirm multiple sclerosis. Now, our focus should be ALS, and that's why I will show you a typical result of ALS patients. Here we do CSF analysis, or we used to do CSF analysis to rule out inflammatory process. Nowadays we do CSF analysis for suspected ALS cases also to prove the neurodegenerative diseases, like we do it meanwhile also for dementia cases. And here we have no signs of inflammation. Cell count is normal. The protein diagrams show no intrathecal synthesis of either IgG, IgA, or IgM, but we see albumin quotient elevation slightly. So we have ruled out inflammatory process. Cytology, lactate are normal, immunoglobulins as well, and also the very sensitive oligoclonal IgG band methods. Here in CSF and serum we don't see any bands. These bands are shadow bands, which are not real bands. And so what we have here as a finding is a mild elevation of the albumin CSF serum ratio, which means a blood CSF barrier dysfunction. This result we see in about 20% of ALS patients. The remaining 80% are usually completely normal. So what does this mean, this blood CSF barrier dysfunction or elevated albumin quotient, which happens in about 1/5 of all ALS patients? Does it have any causal relationship with ALS, or is it unspecific? Does it correlate with disease onset? No, we don't have any proofs for that. Does it correlate with progression rate, rapid versus slow progression? Maybe, and we have here a new data by Veronica Klose published in this year, where we could show on more than 1,000 ALS patients that in younger patients who are males, elevated albumin quotient correlates with survival. So this is the entire group, males and females, and we see a tendency that elevated albumin quotient may correlate with shorter survival time, but it was not significant. If we split this patient group in males and females, we see that the driving force for this, which becomes significant, are the male patients, especially in younger age. If they have elevated albumin quotient, then the survival time will be shorter. More explanation for this we don't have yet. Then we also, a few years ago, we also looked whether albumin quotient is correlating with hypercapnia, which some ALS patients may have. And here indeed we see a weak correlation but the numbers of this patient, the sample size was too low to draw any firm conclusion. So this issue still needs further exploration. And what about the oligoclonal IgG bands? Usually in ALS patients we don't see oligoclonal bands, but in 10 up to 10%, oligoclonal bands may be visible as type 2 or type 3. This would be here, type 2 or type 3. And this is not significantly different from other disease groups like Alzheimer's dementia, MCI, tension-type headache, or facial paresis. Especially in elder patients, up to 10% presence of oligoclonal bands may happen. Less in facial paresis patients, but in MCI or tension-type headache we see it also. So it has a comparable prevalence of OCD patterns in ALS, but the presence of OCBs, if they are present, then there will be no association or relationship with disease progression or of prognosis. So let's get to now beyond the normal CSF analysis to new biomarkers. And here we have the candidate biomarkers which may be related to the ALS pathomechanism. These are astrocytic reaction, neurotrophic factors, microglia reaction, oxidative stress, but also neuroaxonal degeneration. And here there are many parameters that have been looked at, and I will focus specifically on the neurofilaments because this is the most important biomarker in the ALS diagnostics and treatment so far. So what are neurofilaments? These are neuron-specific structure proteins located in the axons, and they determine the axonal diameter and account for 13% of all neuronal proteins. So they are pretty much available in the nervous system. And there are 5 subtypes known, and most well studied isoforms are the neurofilament light chain and the neurofilament heavy chain, amenable to assays which are meanwhile present in routine analysis. And what we know is that the concentration of neurofilaments in CSF and serum show a gradient of 50 to 100 times higher in CSF than in serum. So if the axon is damaged for whatever reason, independent of the etiology, it can be pressure, it can be a trauma, it can be inflammation, it can be a degeneration, then neurofilaments will be released into the extracellular space, or if in the peripheral nervous system, directly in the environment. And if in the central nervous system, then they will go into the extracellular space, and from there to the CSF space, where no real barrier is present. And then they might also appear in serum. How the way from the central nervous system into the blood occurs, this is still a subject of discussion. I will show you now some data of neurofilaments in CSF. This neurofilaments in CSF is not really very new. For several years, this has been already analyzed, and we in my group, we started to work with neurofilaments in CSF at that time with homemade assays, and looked at ALS patients compared to controls and Alzheimer's disease, and saw that neurofilament heavy chain, at that time we had a good assay in cooperation with Axel Petzold from London, and here we saw that ALS shows significantly elevated neurofilament levels compared to controls, but also to Alzheimer's disease patients, a disease where also neurodegeneration occurs. So this was very interesting, and this elevation in ALS appeared to correlate with rapid progression and also a little bit with upper motor neuron disease. And then a long time there was no activity, and later on neurofilaments became more interesting and attractive, and then in our clinic the group of Markus Otto together with Petra Steinacker analyzed a much larger number of ALS patients, looking not only at heavy chain neurofilaments but also light chain neurofilaments, and correlated with survival in ALS. And that what we have described 10 years ago in a smaller sample size was confirmed. The higher the NfH levels, the shorter the survival time, and the heavy chain showed better correlations and better discrimination between low and high neurofilaments level than the light neurofilament isoform. Here is also a significant difference, but the discrimination is not that good. So this seemed to be a pretty useful parameter, and there was a cutoff defined to distinguish ALS patients from controls and other neurodegenerative diseases. So, but how specific are neurofilaments in neurological diseases? And here we can state that neurofilaments are not disease-specific. Neurofilaments occur in almost any neurological disease where axonal damage occurs. As you see here, these are the controls, and the highest levels are seen in patients with HIV and dementia, and then ALS, FTLD will follow. And here we have all other neurological diseases, including Parkinson's disease, including MS patients, and so on. CSF analysis can be done, but usually only once. For differential diagnostic purposes, it is definitely helpful, but if we want to do follow-up analysis, then blood is of course more interesting. Although the concentration level is very low, it can be picked up by new technologies like the Seymour or Ella, which are able to measure lowest picogram or even femtogram concentration levels. I will not go deeper into the technology, but the analysis using this technology in blood showed that in case of ALS can be distinguished from ALS mimics and other degenerative controls, as well as we can do it in CSF. And the cutoff was here almost 10 times lower than in CSF. It was here 45 picogram defined, and this with this we have a discrimination rate of 80% compared to the control patients, which is also not that bad. Now, the problem with the cutoff is that it does not take into consideration the age dependency of neurofilaments if you define one cutoff per disease, because it is very obvious that serum NFL and also CSF NFL shows a very strong age dependency. Here are the 40 years of age, around 20, 80 years of age is around 80 and higher. These are the percentiles here. So if you want to define cutoff values, then you definitely have to take into account the different age groups between the age lower than 20 and higher than 70 days, a 5-fold increase of the cutoff value, which might be important to avoid any misinterpretation or under or over diagnosis of a patient. So this is important to have an age-dependent evaluation by percentiles, or even better by Z-scores. And here is the one of the latest recent studies here from Ulm, which is a population-based evidence for the use of serum neurofilaments as individual diagnostic and prognostic biomarkers in ALS from a ALS registry in Swabia, where a very high number of patients have been collected, around 800, and then also population-based controls, around 600, and some disease mimics. And here you see, these are the controls in blue, and here the ALS patients in ALS, and you see again the age dependency in both groups. And interesting is that the age dependency in the ALS is not that, in higher ages, not that prominent as in the normal controls. And here you can define also the different Z-scores by showing the different stages of the Z-scores up to 2 standard deviations. And here we could also define the 90%, 95% cutoff specificity depending of the age groups. What did Simon Witzel and colleagues of this study what could they describe? They could describe that the phenotype and the disease progression impact the diagnostic ability of this parameter. Here we have the controls, and here we have the classical ALS, and we see that, for instance, primary lateral sclerosis is much lower regarding the Z-scores compared to the classical ALS. And if you evaluate the disease progression in this ALS group based on loss per month, disease progression, and here you see that highest disease progression correlate with higher Z-scores. And here again, as a visual illustration, here are the phenotypes, clinical phenotypes, and here are the disease progression parameter per month. And the higher the progression loss per month is, the higher the receiver operating curve area under the curve, as you see. And here you see that the different ALS phenotypes also correlate with different Z-scores. Maybe the most important part of this work is that an SS, neurofilament SS score could be defined, as you see here. Here we have the neurofilament SS score going from 1 to 9, the lower the better, and then we have the neurofilament levels, so the lower NFSSS score is correlated with the lower neurofilament level and with lower or negative Z-score, and the higher NFSSS score is correspondingly correlated with higher neurofilament absolute values or with higher positive Z-scores. And here you see the distribution of these different groups, and here you have also in color bar the survival, the median survival of the patients. So by having the SS score, you can judge the median survival time. So the higher the SS score will be, the shorter the survival time, the lower SS score, the higher the survival time. And here are an illustration of the Kaplan-Meier survival, which gives you the same information as above. So let me get to the end and summarize what I have tried to present in my lecture. CSF is an important biomarker in routine and in research, complementary to imaging and electrophysiology. It's a neurochemical diagnostic window for central nervous system diseases. It is important in routine to sample sufficient CSF and serum because it's usually done once, and many tests should be possible to do out of it. It's important to have a CSF laboratory close by where this CSF is taken. The transfer time should be below than 2 hours. This is important because of the cytology. If you want to do CSF sediment with differential cell count, the cells are stable for up to 2 hours. Otherwise, you cannot do this, and you can have only this protein diagnostic. So then in the laboratory, usually stepwise analysis is done, as I showed you, the emergency part, basic program, extended program, and then these multiple parameters are combined, integrated in a total result and evaluated by results in context with the clinical findings. And for the second part, I tried to show you as an example for neurofilaments, NFL and NFH, that the brain-specific markers for specific diseases are well established. I showed you examples for ALS, but also for Alzheimer's disease and mild traumatic brain injury or inflammatory disease like MS. There are also established markers. In CSF for differential diagnostic aspects, but this analysis of brain proteins in serum are of course also important because they help to monitor disease activity, disease progression, and is used as a predictive biomarker in clinical trials and meanwhile also in real-world cohorts. And the set score evaluation significantly improves the prognostic power compared to absolute raw values and validates the longitudinal stability. So, and here I come to the end. I would like to thank my co-workers in the CSF laboratory, biobank team, and also my research team who all contribute to our biomarker projects, and of course the collaborators of the ALS team, Albert Rudolph, Johannes Dors, Simon Witzel, Max Wiesenfahrt, and Monika Klose, who contribute a lot to the ALS research in Ulm. I also would like to thank you for your attention, and it was a pleasure to share with you my data. And if you have any question, I'm happy to take them. All the best and have a nice remaining conference.
احنا كده وصلنا مش موجود. وصلنا
Hello from Ulm to Cairo. Many thanks for your kind invitation to this nice conference.
احنا كده وصلنا لختام اول يوم من المؤتمر. ببارك للدكتوره ناجية على النجاح الكبير، وقبل العشاء ان شاء الله اللي هيبقى في قاعه عابدين في جروب فوتو، يعني ادعو اساتذتنا وزملائنا يتفضلوا على الستيج، ويا ريت نخلي اللوجو بتاع المؤتمر في الخلفيه.
اتفضلوا معانا جروب فوتو بعد اذنكم. طبعا انا بشكر بروفيسور توماني، هو مسجل المحاضره دي مخصوص عشاننا وقعد اسبوع كامل يسجلها عشاننا. ان شاء الله المره الجايه هيبقى معانا بيرسونال وفيزيكالي ويحضر معانا ويضيف لنا من علمه. اتفضلوا.